let's have all of the speakers who remain with us, if we could, join the highlighted section here, if we could, Catherine. Feel free to keep putting your comments in the chat. I've pulled a lot of the ones from earlier. And we'll also, obviously, if anybody has additional questions, please go ahead. And thanks to those of you who just did. Maybe I'll just start first. I think we're still missing a couple. Do we have Vicky? To make sure we get Vicky back in here. There she is. Wonderful. Welcome back. I know Lisa Sunan couldn't stay with us, but she certainly made a lot of provocative comments that I think we'll have some good discussions about. And also thanks to David Rue for answering a fair number of the questions people left for him. So let's start. Maybe just as a first question, I want to see if any of you have questions for each other. I think the first panel brought up so many big issues, and I think the second panel said, well, here's what we've done about it. Any reflections, thoughts among any of you before we start taking questions from the audience for some of the ones I've pulled earlier? I'm just going to go ahead and get started then if you don't. So here's your chance. So here's the first one. I was really struck by a comment you said, Vicki, that we should not repeat the same mistakes we did from when we did EHR implementation. I think what we heard from a couple of the innovators in the second panel was that they are kind of going about implementation differently. And lots of the comments earlier on were about how do we get this implementation to scale? How do we get to sort of plug and play? So implementation was a big theme. Any reflections from any of you about what it would take to really bring some of these innovations to scale? And anybody can start.
Yeah. This is Steve O'Mahony. I really would also continue to focus on the ability of the modern FHIR API standards and the interoperability as really taking advantage of that. But I think also the clear message from my colleagues is really focusing on those key items, the partnership between clinicians and the technology, to really focus on the items that are most causing us trouble, right? And I think that continued partnership of those on the ground and taking advantage of the research. So let's continue to build on this, because it's such an open. If you look at the whole thing, the universe is so big that you can get lost. But when you look at focus on the research that has been done already, to know not what we think is causing problems, but what we know is causing problems, and then also what are the problems that, if we are to intervene on them, will have an effect on your well-being and your continuing to stay in the workforce. Then that's where we, as the innovators, can continue to use those. The barriers are reduced, but let's actually focus on the priorities that are going to do the most good first, and then continue to work together and continue to evolve.
Great. Anyone else reflect on that?
Yeah,
Michael?
I'll comment as well. A lot of what drove the speed of implementation was high-tech meaningful use dollars following brand study and others, that just digitizing health systems will in fact lower cost, improve the safety of care. And I think the mistake we made was the speed implementation and the belief, and the misguided belief, that the systems will just magically work and make it easier, more efficient. And that really hasn't proven to be the case. I'm not implying that the systems in themselves have made healthcare less safe. I'm not saying that, but I am saying that it didn't result in the efficiency and effectiveness that was believed that by digitizing would occur. Prior to really high-tech meaningful use, as you also saw best of breed, where people within organizations would pick the best lab systems, they would pick the best cardiology systems, and then part of that really was going to a unifying platform. And so a lot of the core functions on an Epic or Cerner or Allscripts, et cetera, are administrative. How do I get an order in? I was a pharmacist before I went to med school, and actually how I got involved in healthcare IT was, as a resident, they wanted me to start doing order entry. I was like, well, I did that as a pharmacist. I don't want to do that as a physician. And so I've evolved my thinking, but the systems haven't evolved equally. They really aren't showing that contextual synoptic information to help us make more informed decisions. All they're doing is making it a little bit safer, for that transcription process of taking from what's in my head into a digital order and automating it downstream. That in itself brings some safety. I'm not implying it isn't, but it really hasn't elevated that level, hasn't brought us to that comparative effectiveness, hasn't brought us to that just-in-time information that we all need. And there's lots of opportunities. I'm waiting for the decision support that says, you've ignored this 3 times compared to your peer group, and your peer group that follows it has better outcomes. And that's really not how it's designed to work today. So,
that's
thanks.
fascinating. For somebody with a quality lens, that's the whole science of benchmarking. And I don't think we've ever really thought about benchmarking your performance in these ways. Vicki, I saw you came off mute. Did you want to reflect or respond?
Yeah, thank you. I'd just like to jump in and actually connect it to some of the comments in the chat. I think one of the interesting pieces around the decision support is really making this major shift to shared decision making. And I think we have, maybe nibbled around the edges there, but we are not there yet. In some of the work that I have done, especially looking at some of the younger generations, the expectation is that they are actively involved in their care and able to share data and have easy access to their data. So I think some of those pieces really need to be considered in the design and development of technologies. We see a little of it on the implementation side involving patients and clinicians, but how do we shift that way up front? In talking with startups in the mobile health space, very few of them actually have nurses or clinicians sometimes on any of their teams. And I think that is really glaring. As nurses, most trusted health provider, we are interacting and answering questions from patients and families about health IT every day. So we know exactly where the issues are. So I think we need to figure out how to close those gaps.
Yeah, I completely agree. And lots of comments as well about patient engagement in the chat as well. Lisa R., and then I'll get to Jessica. Go ahead, Lisa.
So reflecting on some of Jessica's points and then also the points in the chat, in addition to the patient perspective, I think we need a perspective of the team and how our technologies fit into the team and the processes, because that is what's ultimately going to help us scale beyond the individual clinician to make these technologies just part of our workflow rather than something that we have to be educated in and trained in to help us work together better. And I appreciate Jessica bringing that up in her data.
Thanks, Lisa. And I love the chat comments, especially about, and everybody's comments about the importance of both the clinician input into all of this and also the patient perspective. And I'll tell you, that is something that we have been surprised, but really excited to see. So a lot of organizations, especially in the telemedicine space, because this was such new technology for most places, really looked at the data they were getting from their patients, and they recognized that while, for example, the individual physician was able to communicate, the patient was not having the same experience with the clinic, the team, the staff were not felt to be part of the team. So they've really retooled their telemedicine kind of portal process based on the feedback they're getting from patients. So I think that it is so important that somebody else's slide, maybe it was Lisa's, we're talking about how it's so important that we implement all of these and then we look at the data to see how people are doing with them, both our providers and our patients, and evolve, because we know we're not going to get it right. The other piece I wanted to stress is the importance of segmenting. And a number of folks talked about this. We as clinicians are not one size fits all. Even within a profession, we are so far from one size fits all. So figuring out what each cohort is going to need, we are going to have to ask them to get that feedback and then design things that are much more tailored than what we're currently doing today.
Yeah, Jessica, that's interesting. One of the questions specifically for you was, it's really fascinating to see those differences by gender, for example, of being able to decompress. But do we know what solutions work? And I think what we heard from Lisa's presentation was there are really striking differences by specialty as well. Reflections on how, while we're differentiating, we could come up with solutions that are more appropriate to the actual workflow in front of a given clinician?
So I have some thoughts on this, and Lisa, I'm sure, has some thoughts on this. So So one of the things I think we need to do kind of sooner rather than later, especially as we're waiting for our tech to evolve and then integrate it, is to really look at the workflow in the clinic. And there's a lot of comments in the chat around system as well. And I would also kind of segue this with what I think Vicky said also, like, staffing is tough right now everywhere, and it's really bad. It's worse than it's ever been. And we all hear about it for nursing. And it is true. We have never seen what we're seeing right now. And it's not just in the inpatient setting, it's in ambulatory as well. So figuring out how do we use the resources we have and the staff that we have to address even these technology challenges right now is so important. And yeah, it's going to take a little bit of work, like rolling up our sleeves and looking at the current process and then evolving it. And it's not going to be just a tech fix. It's going to be, does that, physician need to be getting all their in-basket messages? How do we better integrate some of these really cool tech solves so that doesn't happen anymore?
Yeah, those are great points. I was really struck by something else Lisa said as well, soon before she dropped off, that, and I think maybe I'll turf this to you, Steve, since you presented some really compelling data on how the tech solution you've used has really made a difference. She said, how do we get to the point where you don't have to prove that new tech actually drives new revenue? I thought that was really a compelling comment. Any reflections from you, Steve? And I see Lisa nodding her head, so I'll go to you next.
Yeah, so I think in the essence, we have the triple aim, right? So we can't look at anything just in isolation. So I think part of this is the reality that we do need to measure, right? We have to measure outcomes, not and we have measured outcomes. Wellness has to be one of them, at least, where it wasn't before. But also, it is at the core of it, you still have to do wellness and safety, right? And financial stability. So I think that's why I highlighted one of the issues was, why can't you do them all? Like, when actually being able to deliver to me, I'm a busy physician. I have a million things going on. And the technology now that we've reduced the barrier, that TAVR I brought as an example, because that is actually a cost. It's first of all, it's a patient safety issue. It's better for the patient, right? It's better for me as a clinician, but it also generates proper revenue. There's nothing wrong with that. And I think that we owe it to the business partnership that we can't work in isolation. So we can still do the safety is first, right? Patient care and safety is first. Our wellness is right there with it. But we also have to make care better and also understand operations, length of stay, and finance. And I'll leave it with it is that also, this is also what we're talking about is high reliability science. So when now that we talk about intelligent decision support, it matters not just that you're delivering it, but how are you delivering it, right? What are you delivering it, and what is the human factor? So I think what we've been able to do is now we're finally able to do this and not just think about it. But I think we do have to make sure the triple aim, and that we honor the reality of operations and tech and finance as well.
Great, thanks, Steve. Lisa?
I'll highlight this from two perspectives. So we certainly should be looking at well-being, first of all, and but as we were talking about, that doesn't always translate directly into increased revenue. And so the question in my mind is, what else could we be doing with that time, even if it doesn't directly translate into increased revenue? Our systems are at varying levels of the transition towards value-based care. But one of the things I see in my role is physicians, when they're spending their time on messages and documentation, it takes their time away from thinking about the health of their panel and populations. And so as we transition more to value-based care, some of these efficiencies may not directly translate into more RVUs, but hopefully they are translating into better health and better quality outcomes for our populations. And I'll just highlight the point around equity in our workforce again. We know that women physicians have better outcomes in certain clinical circumstances, and freeing up their time may not mean that they see an extra patient or they generate more RVUs, but it's allowing them to do their job in a sustainable way. And so they're not turning over or cutting back on clinical time and improving outcomes for our patients.
That's great. Michael, there are a couple of comments in the chat, and you really emphasized the importance of what was happening in terms of fire standards, et cetera. There's a comment, for example, about, for example, if we have to ensure compliance with things like ICD-10 coding, how do we ensure that some of this documentation doesn't trigger, coding compliance doesn't actually increase burden on clinicians?
Yeah, I'm going to answer that question, but I want to make a comment preceding it, if I may.
Please.
One of the things we have to look at in any of these summary systems and or ambient systems is the role of clinical decision support. And so one of the beliefs, one of the goals was that the systems would be, and I referenced this before, so I won't repeat it all, would really help improve the quality of care, the clinical decision support. So we have to be cautious on, if we over-rotate in making the technology fully invisible, what is the cost and consequence of showing some of the panel information, making sure healthcare maintenance reminders are addressed, or clinical decision support down throughout that care. As far as compliance, I think there's two portions of it. One is looking at it in the context of natural language processing, computer-assisted coding, and other technology, that it's a byproduct of that interaction is a work product that can be used by others. And so other coders, other billers, other auditors. The second is actually using your tools, right? So some of the before and after is, it's a broken system before, so I show it slightly better. How much do we really celebrate that in the context of how it should be? And so we also have to look at the system to make sure that the people are coding appropriately. I'll give an example. We look at the amount of time spent in documentation in the context of the length of their documentation relative to the amount of copy and paste they're using. And so if we see people that have very long notes and are taking a very short amount of time, it tells you that they may be overusing some of the copy forward, copy and paste. And so it's not just at the level of the code itself, but the general practice to make sure that people aren't getting sloppy or potentially or inadvertently abusing some of these tools. Because it's easy to construct a note that will comply with these rules. It doesn't mean it's actually a useful, meaningful note. Anyone that's gone to Canada and sees a very efficient note and then comes to the United States and we'll see an orthopedist note that's 18 pages long. I've seen many examples of those, where they're putting every x-ray, every single thing in there, has to question, is the technology really accomplishing what we hoped?
Another comment that was actually to David's presentation earlier, but I think is applicable here as well, was so much of the promise, for example, around using NLP and some of these newer technologies. How much does it require checking to make sure it's correct? Like, are there ways to do that in ways that ultimately, can you train the technology in ways that still make it ultimately easier for the clinician and ultimately, hopefully, for the patient who may actually get to look at that note, we hope, increasingly and reflect on it, rather than looking at a note that's just tons of copy and paste and pretty hard to interpret? Michael, start with you. Anybody else want to add in as well?
Yeah, so I've spent a lot of time on NLP. I led that group at Cerner. For very specific use cases, the technology works well. You still have to validate it. You have to validate it to, I'm just going to use the term, a gold standard. And so ideally, you're training that note. So against a set, you use different technologies, ontology-based and statistical-based. So are the terms matching up? Are they identifying those terms? Are they mapping accordingly? And are these patterns consistent with what you're trying to accomplish? Once you move it into a clinical setting, you do have to go validate those notes. And the ambient example that was used before, the direct to computer, there's many steps before it goes direct to computer. It's the virtual scribing. The virtual scribe is just benefiting from some of that technology, but the human still has to review it. So it's not yet at a point where you don't have to validate. Ideally, you're validating it. Our orthopedists, some of which are $6 a minute. So think about that. Do I really want to spend their time validating that note? Or are there other individuals that may be 50 cents a minute? Now, I hate to use that terminology, but the reality is we do have to think about it in that context. It's not a good use of a very precious clinical resource to validate what someone else could do on their behalf. But at the end, the docs will still have to review those notes for a period of time.
Wow. Other reflections on that point? So I'm just looking, we've got about 7 minutes left until you get a well-earned 10-minute break before we go to the next session. Please continue to put your questions in the chat. I've got a few that I've been pulling out, sort of, I think they're kind of meta questions because there's so many great comments in the chat. I was really struck, Lisa, by some of your comments earlier about how much of that managing the inbox and that work is sort of places where maybe technology hasn't been quite as deployed. And I know, Steve, that's part of what you've been doing as well. This whole issue of workflow and who's doing the work and how you might think differently about how that could be relieved with technology would be great.
Thank you for bringing this up. I think this is an area where really good design thinking and understanding how we work, so technology companies coming to understand our workflows could be really beneficial. And I had highlighted in my slide something that was honestly surprising to me, that so many of our messages were between each other, or they were from the system. So figuring out how it is we communicate amongst ourselves. Why are we sending each other so many messages, telephone calls back and forth? How many touches does it actually take to resolve the average patient issue? And thinking about, as somebody had mentioned, the use of Slack, for example, what can we learn from traditional consumer technologies about how we can better communicate with each other? Of course, in a HIPAA compliant way, in a way that is documented to meet our patients' needs. But it really highlights the fact that there have certainly been positive effects of the EHR, and it has created consequences we couldn't have imagined. But it's where I would really encourage people working in this space to come spend time with us, to talk to us about what it's like, and then also to talk to us about what it's like in different specialties. Because the workflows are really quite different. What physicians take on is different, and it's also different in academic settings versus community practices versus many other settings. But that diversity has potential if you're willing to spend the time with us.
Yeah, it's a great point, Lisa. And Tate has done so much work looking by specialty, for example, that the drivers of burnout, in fact, are quite different, which makes logical sense that we then need to hone on, there are going to be some solutions that I think are cross-disciplinary, cross-specialty, cross-disciplinary, but there are clearly going to be ones about the nature of work and how we do it that need to be more tailored. Steve and then Jessica. Any reflections?
Yeah, I think just briefly on that, I think working to the top of the license is there's many, I think we're getting at many dimensions to this concept, but that's another very valuable dimension. And I think, we have pharmacy techs who do a great job of medication histories that makes me able to do a med rec so much better and easier. So really it honors the person in that role. If they can work to the top of their license, do what they're so good at, that is so complementary to the rest of the team. And then therefore delivering the tasks in the right way to the right people, and then automation automatically communicating that without having to interrupt is really a great concept. And finally, Michael says that it's as easy to replicate a mistake as it is something good. So I think we always have to keep in mind validation and verification so we can use them as building blocks and then keep moving forward.
Great. Jessica.
Yeah, so I fully agree with everything that Lisa and Stephen just said. And I think that those are both so important. And I just want to add something, and it's something Stephen mentioned earlier, which is about like reliability science and really leveraging high reliability principles that many of us, I think, are very familiar with from the world of safety, and using that as a chassis or foundation for what we're doing in all aspects of our care right now. So because we know that, we can get it right one time for one patient, but to be able to do this in a systematic way reliably so that it's right for every patient every time, we have to put the system and the infrastructure in place to do that. But as important as what Lisa and Stephen just talked about the system and the infrastructure, is the relationship and connection of the people on the team. And I know we all know that, but putting the time in to build that trust, to create that connectivity, we see, and you were asking, do we see practices or places where this is happening better than others? And we do. So those organizations that have really leaned in and score high on things like trust, like involvement in decision-making, like respect, they end up having better outcomes, both for patient experience and engagement, but also for their staff and their like willingness to stay and not leave. So I just want to make that this is the humanware point of what we're talking about, because we do all these great tech stuff, but if we skip that kind of high reliability, trust, connecting, involvement in decision-making step, we're not going to get where we need to get.
Those are great points. Vicki, did you want to weigh in?
Yeah, absolutely. Thank you for that, Jessica. I actually wanted to connect this back to the NLP point as well and tangent a bit off of that. So there's been, some interesting studies coming out over the last few months on the impact of AI on our COVID work, right? And it's all showing that, nope, didn't move the mark, right? So I think, what we're hearing here today, these human pieces, the people issues, the inbox, while these might not sound like bright, shiny objects, they're really important. And I think we sometimes miss that because we just go right to those shiny objects. So thinking about some of this foundational work and having the opportunity to share it here today is very important.
Great. Thank you so much, Vicki. On that point, we're at, let's see, I don't want to deprive you of your break. It's 11:59. So I just want to briefly thank all of our speakers from this morning. It was really such a rich conversation. I have pages and pages of notes, and I think we're all looking forward to getting to the website and logging in and seeing all of your slides. Just to let you all know, we're going to have a 10-minute break. We'll reconvene at 12:10. Chris Castle will introduce session 3, and then please save all your comments and ideas because we will have a breakout session later in the afternoon. We really want to collect your thoughts and ideas about how we actually move some of this great innovation into more generalized practice. So thank you all so much. Have a great break. Thank you all to our speakers. Bye.